Good evening, everybody. I think I am being prompted to start. I hope everybody is doing well and safe in the confines of your homes. I'm wondering if you can hear me clearly. Okay, thank you. So the title of my presentation is The Road to a Clean Bill of Pediatric Oral Health. I have been tasked to talk about 5 aspects, right? So first is about the first 1,000 days of life, and then the dental home, something about a little time on minimal preventive and restorative strategies, the Hall technique, and maybe we can discuss briefly about the new normal. So the power of the first 1,000 days is also known as the window of golden opportunity. All right, so my animation is not working, so you're just seeing my slides as is, no more animation. So I'll just proceed according to each slide. Sana meron sana akong ginawang mga dramatic effects pa pero hindi pala makikita. But anyway, what's important is the content. All right, so there is increasing evidence which suggests that the health status of children during the first 1,000 days of life directly impacts the trajectory of children's lives. And this influences the long-term health outcomes, with nutrition playing a major role. This affects the risk of acquiring chronic diseases later in life. Chronic diseases like obesity and diabetes, and we all know that dental caries is also considered a chronic disease. And whatever happens in the first 1,000 days of life will dictate the risk of that individual in obtaining these chronic diseases, and will also have an impact on the developmental outcomes of that individual. When I say in the developmental outcomes, that would include the educational achievement, the earning potential, and the human capital for that particular individual. And this is applicable for everybody. So what this slide is saying is that when implemented properly, optimum nutrition can have a lifelong impact on a child's future and help break the cycle of poverty. So it's not just the 1,000 days of life is not just about anticipatory guidance for just for the sake of pediatric dentistry, but it has an impact overall in public policy, in the general well-being of one person, and also eventually on the human population. Any problems in the first 1,000 days of life, like undernourishment and malnourishment, result to wasting and stunting. So if there is wasting and stunting in the short-term effects are these, and the long-term effects can be even more detrimental. If preventive nutritional interventions are provided in a time-appropriate program, then slowly but surely the cycle of having poorly nourished mothers and their children on the growth and development potential of the population will be positively addressed. There is clear evidence favoring lifestyle interventions and supportive environments from both a preventive and treatment perspective. So early intervention is more clinically effective and considered more economically viable. Change must start in the early childcare system where limited resources can be used wisely, especially here in the Philippines. So this is a case study wherein the project aimed to implement and evaluate a nutrition strategy to improve the nutritional status of young children and pregnant mothers in area in Palawan. So this, as I was saying, this project aimed to improve the nutritional status of young children and pregnant mothers in an area in Palawan, done in 2015. There was a sample of 6 to 35-month-old children, including their pregnant mothers. There were two groups, a control group, which received regular community services, and an intervention group, which was a complementary feeding group, which also received nutrition education, and they were also provided resources to have a home vegetable garden. So the result was, number one, the mean weight and height and the difference of means with the nutritional status of children using the anthropometric Z-scores were highly significant in the intervention group. The intervention group, remember, is the one which had complementary feeding plus nutritional education plus a home vegetable garden also. Second result is that the decrease in number of anemic pregnant mothers in the intervention group was significant. This is indicative that the supplementary feeding was effective in lowering the incidence of iron deficiency anemia in the pregnant mothers. And the last result was that the increase in mean score of the pregnant mother's nutrition knowledge from baseline to end line has significantly proven the value of nutrition education. So it is a very promising result, very promising project. So this just proves that investing in the first 1,000 days of life can really be helpful, not just in the short term, but in the long-term run. So as I said, investment in the first 1,000 days of life is important, but we should not forget that investing in the next days, the next 7,000 days during middle childhood and adolescence are just as important. So if we want to achieve general improvement in the growth and development of our children, it's good to focus on the first 1,000 days of life, but not forget also the remaining 7,000 days during middle childhood and adolescence. So let's talk about the dental home now. And in this slide, you see that the dental home has benefits of appropriate care. It can reduce treatment costs, and it has access. Now, it provides access to an otherwise impossible or unavailable services to patients, especially child patients. Reduced costs because those who delay a first dental visit usually requires more treatment services. And unavailable services mentioned here may include emergency dental care, because it is believed that majority of children who has caries-related emergencies had no regular source of dental care. So you see here, ideal characteristics and practical advantages of a dental home. Just to focus on the characteristics, a dental home should be accessible, family-centered, continuous or consistent, comprehensive in their dental services, coordinated, compassionate, and since this article was in the United States, they included culturally competent, because the most underserved and unserved population in that part of the globe usually belong to the minority group. So this article was released in 2002 by Novak and Casamasino, and holds true until today. Basically, a dental home provides anticipatory guidance to the parents so that they are aware of their children's growth and development, as well as possible risk factors as the children age. Also, preventive interventions can be personalized to the needs of the child. And when a child has been observed for a certain period, developmental milestones, and natural growth and development can be recognized, which may lead to other recommendations like orthodontic referrals or medical referrals if needed. And this is especially important for children with special healthcare needs. Lastly, here you see periodic revision, periodic supervision, and because recall matters, scheduling recall appointments prior to every patient dismissal will help in patient education and create better awareness for oral health. So if there is no dental home, then the likelihood of having a caries-related emergency is also very high. In this article, this was a 1994 article, again, still holds true until today. This was in the United States also. 52% of the sample size belonged to the less than 3.5-year-old population. And they all had caries-related emergencies. And out of the 1,482 children seen from 1982 to 1991, 62% had a dental emergency. So basically, the majority of children whose parents sought emergency dental care for them did not have a dentist. So if there's a dental home, of course, we are able to see children early. And so we can focus on infant oral health. And when there is infant oral health, then parents can receive preventive instruction. Parents can establish a dentist-family relationship, hence a dental home. And in most cases, the health professional can apply fluoride varnish to the child's primary teeth on a regular basis. Okay. And a major goal of infant oral health is to identify children at risk for early childhood caries. So actions can be taken to prevent it because once caries is there, it can be a lifetime infection. And although oral bacteria and their acids are frequently listed among the causes of caries, without sugar, caries would not occur. So when there is infant oral health, focus on that would intervene in this process in two ways. First is with dietary modification and the institution of tooth cleaning, mababawasan yung problema, no? Less sugar consumption, removal of the plaque by oral hygiene. Therefore, the host capacity is able to clear cariogenic species. You won't be stimulating acidogenic and aciduric cariogenic bacteria, and together with additional preventive strategies like fluoride exposure, you will be promoting enamel remineralization and repair. So it's good. This article reiterates the importance of collaborations between primary, medical, and dental providers and recommends that studies should be done to identify infants at high risk for dental caries based on their own unique variables that are routinely collected by usually the pediatricians during well child care visits, and that positive predictive findings may lead to a caries risk screening integrated into the workflow of a primary care professional's checkup of a child, a well child, to aid in identifying and referring those at highest risk for dental intervention and help facilitate consistent integration of oral health intervention into well child care visits. So I'd like to emphasize here this article, part of its commentary, saying that the two most underused oral health prevention and promotion tools, which are very easy to do or should be very easy to do, are infant oral health and provision of a dental home. This was released in March 2019. So moving on, we go to prevention and restoration, because if the prevention strategies fail and caries becomes apparent, then there is no other recourse but to address that caries lesion. Historically and globally, childhood dental caries has been managed two extreme ways. First, a highly interventive and expensive treatment where children undergo invasive procedures, often under general anesthesia, to have a dental rehabilitation or an oral rehabilitation. Second, if a GA or an oral rehab is not possible, then treatment is simply not done. Waiting for the caries primary dentition to exfoliate naturally, hoping that it does not cause any more problems for the meantime. So looking at this map, caries prevalence and caries experience of primary teeth in Asia, or Southeast Asia in particular, from 2006 and 2015. This is how the caries map in our region looks like. This demonstrates high caries prevalence with a high level of caries severity, especially for this region in Southeast Asia. The overall caries status of preschool children is actually worse than for those in diverse parts of the world, and it is almost universal in Southeast Asia. What is striking about this is that studies on early childhood caries and risk factors in Southeast Asia remain largely underrepresented in the literature, although this region shoulders a disproportionate caries burden. So looking at our figures in the Philippines, we have been consistently included in the top list of countries in the world with a high caries prevalence. And it is a commonly seen disease in the preschool population, where it is considered typical and families treat it as acceptable, since baby teeth would usually be replaced anyway. That's what they usually say. And so because of this early childhood caries, if I may say, epidemic, the IAPD, or the International Association of Pediatric Dentistry, called on a consensus, or organized a consensus conference back in November of 2018. I think some of the PPDSI members were there to participate. And as a result, was released from that consensus conference. So the action on early childhood caries from multiple stakeholders is needed in four key areas. And the priorities are: one, to raise awareness of early childhood caries; two, limit the sugars intake. Sabi nga po dito sa conference na to, there should be zero sugar intake for children who are 2 years old and below, kung kaya. Okay? If it's really realistic. Third, perform twice daily toothbrushing. And fourth, provide first preventive guidance. So this is a well-recognized chart created by Dr. John Featherstone. And he believed that the dental clinician should better understand the key factors and risks that swing the balance between caries and no caries progression, depending on how heavy it is on one side or the other. So the WREC, or REC factors, which include white spots, restorations less than 3 years old, and so on and so forth. They represent the disease indicators, while the safe are the protective factors: saliva, antibacterials, fluoride, effective diet. Recently, there's been an update. And in this update, risk-based assessment or reassessment has already been included as part of the protective factors that may help turn the balance towards health. If before this was not in the figure, experts must have found good scientific basis for the use of a caries risk assessment model. So we better incorporate it in our diagnostic tools, especially if we're looking at very young children, so that we can screen early for early childhood caries. So the caries management plan is to prevent the onset of caries across the lifespan. Specifically, we'd like to be able to do tissue regeneration through apt prevention and the arrest of the disease process and maintenance of as much tissue as possible. And how do we achieve these goals? First is by topical means, where either biofilm is removed by toothbrushing, um, sometimes opening up the cavity, or the biofilm ecology is altered by the application of medicaments like fluoride, silver diamine fluoride, or by reducing the sugar intake. Or secondly, sealing in, wherein biofilm is isolated from dietary sugars by sealing the bacteria in with a good restorative material. But once a disease is present, we deal with the challenge of determining the appropriate approach to stop its consequences. And this is achieved by applying interventions at patient level and also by managing the manifestation of the disease at the lesion level. So there are two kinds of interventions if we have to deal with the lesions already. First, the non-restorative, or also known as non-invasive, also known as micro-invasive. So these are more conservative approaches which stop the disease process through the arrest or reversal of carious lesions and minimizes the loss of tooth structure. And the second intervention is what we are all used to doing, because this is what we have been taught of in school, and that is restorative or minimally invasive and invasive treatments. So it is important to be able to include non-cavitated lesions into our notation and diagnostic systems, and not just note the cavitated lesions. So this is the ICDAS notation system. There are 6 notations here, coming from 0, which is sound. The non-cavitated notations are from 1, 2, 3, and 4. If it's 5 and 6, this belongs to the restorative phase already, while 1, 2, 3, and 4 can still be addressed with the first lesion level intervention. Now, one option for controlling lesion activity is to seal in the lesion. And this inhibits bacterial acids and dietary carbohydrates from diffusing into dentine. For lesions that are bacterially contaminated, the sealing will deprive bacteria from their carbohydrate nutrition, which inactivates the sealed bacteria. And one example of this technique is the ART, or the atraumatic restorative technique. Pwede rin po siyang sealing in via sealants, okay? At pwede rin siyang sealing in via the Hall technique. And we will discuss the Hall technique a little later. And there is also the non-restorative caries control, or NRCC, which is also known as a slicing technique in olden times. This is where carious lesions are transformed into cleansable areas with or without topical fluoride application. So to sum it up, this is from the clinical practice guidelines released by the ADA in 2018. I'm sorry, no, hindi pala ito yung CPG. This is from the European group, no, on carious tissue removal, also released in 2018. And it talked about the different types of carious tissue removal, which we have discussed already. That would include the ART, no removal fissure sealant, the Hall technique, and also the non-restorative caries control technique. And then we have here the traditional caries tissue removal techniques, which may seem more radical now compared to the previous one shown, but this we know very well because this is what we normally do in restorative dentistry. So it's good to review the histological and clinical manifestations of the caries depth for the sake of accurate selective caries dentine removal based on the released guidelines. So this is color-coded based on how deep the lesion is. So you have here sound dentine in this area going to translucent, ito yun, going into the contaminated zone and the necrotic zone here. This clinical practice guideline, which I mentioned earlier, ito yung pinagbasihan ko nung dito galing yung mga susunod na discussion. This is from the ADA, Council on Scientific Affairs, also released in 2018, latter part of 2018. And the clinical practice guidelines was based on a systematic search of known databases like Medline, Cochrane, of systematic reviews to identify random clinical trials of non-restorative techniques that would include both cavitated and non-cavitated lesions. So it's quite a long article, but to summarize everything that they are recommending, what they are espousing for primary teeth, this is decision 3 for primary teeth, and for ease of description of the management options, they have been separated into non-cavitated and cavitated lesions, depending on the surface that we're looking at, occlusal, proximal, and facial or lingual. So non-cavitated lesions, they aim to stop and reverse the lesion, or at least prevent cavitation from occurring. In previous times, this stage, only detectable in radiographs, would have resulted in drilling and filling. But that would mean more damage than good will be done by removing the tooth substance at this stage in order to place a filling. So now if it's a non-cavitated lesion, now here are the options. Can be sealants, can be fluoride varnish, can be resin infiltrates, can also be the provision of mouth rinses, providing fluoride gels, okay? And for the cavitated lesions, wherever the surface is, the CPG is now recommending application of the silver diamine fluoride. And for all treatments, it's important to have regular monitoring. There's also a decision tree for permanent teeth. It is almost the same. Depending on the surfaces involved, you have non-cavitated and cavitated lesions. You have these options. The main difference is that in the permanent teeth algorithm or decision tree, you have the inclusion of root surface caries already. Just the same, regular monitoring is still important. Now, the Hall technique has been gaining more popularity, especially now that we are trying to lessen the aerosol generating procedures that we'd like to employ in providing service to our patients, and it's an alternative to conventional restorations in primary molars. It's actually very easy to do. No local anesthesia is required. No caries removal is required, as mentioned before, because you'd like to just seal in the bacteria and give them a natural death by doing so. No tooth preparation required. And so it's not surprising that this technique is preferred by general dental practitioners and child patients and parents over the conventional method in several articles that I have reviewed. The indications for the Hall preformed molar crowns are as follows. So definitely there must be no pain or no sensitivity, hopefully. It can be a Carious lesion for one surface, can be more. Can be for hypoplastic teeth. It can be for anxious children, those with behavioral problems. Okay. So as long as I think the main indicator here is that there must be no pain felt yet. So how do you do this? Of course, you have to see if it is indicated for the whole technique, and then you choose the size of your preformed molar crowns based on the closest approximate width, mesiodistally. And if you have chosen a crown for trial, then you look for a spring back effect, not unlike the traditional crowns where we want a snap-on fit when you try it on. So you'd like to hear or feel a snapping sound when the crown reaches the cervical portion. For the Hall technique, the spring back feel or a spring back effect once you reach the contact areas. You don't really want to push it all down when you are trying it on. Okay, and when you have the right size, then fill it up with your cement, and then you ask the child to bite down on cotton roll until it's all the way down. Clean everything up like so. Additional considerations is that if the contacts between the teeth are really tight, you might need to put a separator days or weeks before the actual Hall technique appointment. It's good to do prophylaxis and reduce the biofilm load in that area. And since you're not going to reduce any part of the tooth um, for Hall technique, then it is possible to have an increase occlusal vertical dimension. But it's not really a major concern because children are very dynamic. After several days of fitting or cementing a whole crown, it will be adjusting on its own. And when you see the patient again for recall, you'll find that there is no more discrepancy in the occlusal bite of the patient. So in this article, no, not yet the article, but this is the rationale behind the seals the deal um, hypothesis by Marsh. And basically, you just seal the caries in and the bacteria in. You isolate it from nutrients from the oral cavity so that it can arrest the caries process and the bacteria will die a natural death. So in this article, wherein the perception of discomfort experienced by the child was asked, Hall PMCs cause significantly less discomfort, as you see in the blue graphs or the blue bars, significantly less discomfort compared to the control restorations. And when it comes to preference by all parties involved, whether child, parent, or dentist, Hall PMCs were preferred to control restorations by a significant majority. So these are the control restorations. The control restorations were the preferred restorations done by the dentist on the other side of the mouth. So they were either composites or glass ionomer restorations. Right. So we now go to briefly the discussion about the new normal. And guidelines have been coming out in different parts of the globe, including our own PDA. And we would like to focus on emergency care, urgent care, defer any elective care that our patients would demand from us, no? PPDSI has released our own interim guidelines for COVID-19, and similarly, there is a focus on also emergency care, urgent care, and deferring non-urgent care. So, meron akong naka-cover dito kung may animation to, but obviously it cannot be seen now. I posted this infographics here to address any emergency care at home. This is an infographics from IATD, and it teaches the parent or the family how to deal with dental trauma at home, especially those that have bleeding, chipped or broken tooth or knocked out tooth without necessitating the need to see a dentist. But there is something underneath here which I cannot remember because I cannot see, so I'm sorry about that. So let's just move on to the next slide. Right, so this is supposed to be a video I got from Dr. Alicia Ku, a pediatric dentist from Taiwan, and she's saying that in Taiwan they did not really have any form of lockdown. It was life as usual for them. So they did not stop. Like in the Philippines, we had an ECQ and now we're in GCQ. Sa kanila, tuloy-tuloy lang, normal ang kanilang buhay. And the government was in control of everything. The government was testing people, especially those coming from abroad and those having flu-like symptoms. So professionals like dentists who are providing care to their patients can focus on their work. And when they screen patients, this is what it looks like at the front desk. They reschedule the appointment at least 14 days later if they find out that the patient has had or has any symptoms of COVID-19, kahit nga hindi COVID-19, kahit flu-like symptoms lang siya, then they automatically reschedule that patient 14 days later. And if there is any history of outside travel, outside Taiwan, then again, to make sure, kina-quarantine muna nila and reschedule the appointment 14 days after. Level of PPE that you see here, I think is just level 2 because we're not really producing any aerosol procedures here. So, ang importante lang, merong sufficient PPE when we deal with those coming into the reception. And there are also no toys. Dinakante nila lahat na nahandun sa waiting area. No toys at the waiting area and no toothbrushing at the hygiene area. This is supposed to show the reception area. Video din kasi ito. Oh, this is the first. This is just showing how to deal with the front desk. So this one is ready with her disinfectant. So this is also from Dr. Alicia Ku. This is what they use for PPE. This is Dr. Alicia Ku, and this is her assistant. And then they leave their gowns in the clinic for cleaning, and they also have clinic shoes, so they don't have to invest in booties anymore. And then they change into street shoes after they're done. Okay, this is also another video from Dr. Anna Sanares from Australia. And in Australia now, I think they have 0 cases already, and it's not really an ECQ or a GCQ like what we have. So it's like, again, business as usual for them.
So what happened to the patient is that the day before, his father rang saying that he fell over his scooter and hit his teeth on the handlebars of the scooter. Now, during this phone call, the father would have been asked about his medical history of
not
travel,
moving.
if they have been in contact with anyone So today when they arrive, we will be asking them the same questions, and then we'll get them to wash their hands with the hand gel. And then they will be going into the surgery. Only one parent will be coming in.
So that's how they also screen patients intending an emergency appointment in Sydney. Okay. And then for the next one, this is the next video, and this is also, well, obviously an Australian, and he's supposed to be showing us how he rinses before the procedure, but it's not moving on my end, so I don't think you can also see it, but it's a pre-procedural mouth rinse, and PPDSI recommends that for a pre-procedural mouth rinse, we can use either 0.2% povidone iodine or 1% hydrogen peroxide. Okay, so this is the next video, and they are now cleaning after the patient. Just again in the Taiwan Pediatric Dental Clinic. So just cleaning very thoroughly. This is how they do it. Okay. I guess that will do. Okay, so basically PPDSI and PDA are recommending that we try to defer the non-essential procedures. And if it is really needed, then we can accept emergency and urgent care treatments so that we can, lessen the possibility, the risk of us being exposed to the COVID-19 problem. So the non-aerosol generating procedures, as provided by PPDSI in this guideline, would include oral examination, ART, the Hall technique, also extraction, and application of silver diamine fluoride. But hopefully our patient will be very cooperative and not cry, because once a patient cries, then that will be aerosol generating as well. And now there are reports saying that you don't even have to speak or sing to generate aerosol. All you have to do is open your mouth and automatically there's aerosol coming out. So I guess this is my last slide. So my take home is that as much as possible, we'd like to prevent early childhood caries, because we know that by doing so, this provides a life of quality for our child patients. If we're able to abide by the new normal, then this will definitely preserve life. And let's appreciate what's essential. Let's live a life that matters, whether we are staying at home and keeping safe. There is still so much to be grateful for. I am grateful for your giving me the opportunity to be here. Thank you very much for your kind attention. Thank you. Good evening, everyone. Even though I cannot see or hear anybody, thank you for listening tonight. Are there any questions? Maybe I should look at the chat box. Hello, everyone. Okay, so looking at the chat box. Okay, hello to everybody. So just put your questions in the chat box, please, so I can see them and read them out loud before I answer them. All right, from Dr. Vic Medina. Hello, sir. The caries removal procedures in permanent teeth, removal to soft dentine, removal to firm dentine, and stepwise caries removal, do you place interim or permanent restoration? Why? Thank you. In my practice, what I do is I do not put interim restorations anymore. I just put whatever I feel will become permanent restoration eventually, because I normally monitor my patients so they come back for recalls, and so I am able to ask if a problem arose from the restoration that we did. And so if no problem is reported, then we can just leave it like that, and since it's already a permanent restoration. If it is also possible to do an interim restoration and just put a temporary filling, but just in case that your treatment has already worked and it has not provided any sensitivity or pain later on, then you have to put in another appointment to place the permanent restoration. And in children, I mean in child patients, as much as possible, we'd like to lessen the number of appointments. So it's like susugal tayo doon sa permanent restoration na sana hindi na siya magkaroon ng problema. So tuloy-tuloy na siya, hindi na natin kailangang ayusin pa. Okay, thank you, Dr. Vic. I hope I answered your question. From Dr. Daryl Joy Eustaquio, how long would you recommend the separators for the Hall technique? Sa totoo lang po, I have not tried to put any separators yet in the cases that I have done. Maswerte po siguro dahil meron kahit maliit na space in between the molars that I needed to do. But the articles that I read mentioned that separators would needed to be in place from 7 days to 14 days. So it really, you have to recall back your patient to see if the separators have worked. And if you see kahit katiting lang na space, you just want provision, space provision for your crown. But as I said, if makita nyo naman na po pwede nyo talagang isingit yung crown, then again, that reduces the number of appointments that you have to schedule for your child patient. So I prefer that one. The lesser number of appointments, the better for child patients. I hope I answered it, Dr. Daryl.
Hi, Dr. Tess. So sorry. Go ahead.
Dr. Arlene Medina, finally, I have someone to talk to. Hello.
Yes, hello.
So what do I do?
So sorry, we're having
Do I just
technical difficulties on our end. But yes, continue your answer to this question first.
I have answered the question with regards to the separators for Hall techniques. I said that literature, the articles that I have seen recommended 7 days to 14 days. But the key there is to recall your patient at the right time and see if you have created space already. But for the cases that I have done so far, I did not require any separator. So I proceeded with putting in the Hall crowns right away.
Yeah.
Okay. So Dr. Arlene, are you going to ask the questions now, or do I proceed with what I'm doing?
Yes, I think I'm going to have to step in for
Okay.
here.
All right.
That's true. It's even particularly hard sometimes to put the separators themselves.
Right.
So
right.
So,
Baka separator pa lang, ilang minuto ka na doon.
Sometimes going straight to the Hall technique is even easier than putting the separators. So moving on to our next question, Dr. Des.
Yeah.
Somebody is asking, are you recommending that our pediatric patients wear PPEs? If so, is there any particular protocol that we should follow regarding donning and doffing for our child patients?
That is the main concern. When we put on PPEs, there is a particular procedure in donning and doffing that has to be followed very strictly, because if we fail to follow that strictly, then we just contaminate everything. Baliwala ang PPE. So when it comes to child patients, I think that will be the main problem. Iisipin natin madaling magsuot ng PPE, but will the child patients be able to follow proper donning and doffing procedures properly? So I think PPEs can be, not really PPEs. In Thailand, where I trained, they don't put PPEs on patients. This was before the pandemic, no? But what I see them put on patients is like parang it's like a towel that covers the entire face up to the chest area. Yung iba nga depende sa laki ng patient, up to the half the body is covered, and what's open is just the mouth area.
Yeah.
So it decreases the load, the number of bacteria or aerosols that might be coming onto the patient during the procedure. So it's like a cover, but the dentist still has access to the mouth. So maybe instead of, if you really want to lessen the number of the aerosols that will be landing on your child patients, maybe something like that, a cover, but will still allow you access in the mouth, but not really PPE. It's going to be very difficult to do that on child patients.
Yes, that's true, which is why we are saying, the simpler it is for our child patients, the better. Because the more sometimes that you throw at them, the more they get agitated, and that's really not what we want.
Right.
Moving on to our next question, Dr. Tess.
Sure.
Part of the flow chart that you showed earlier regarding the treatment options, there was resin infiltration in that flow chart. Could you expound on this a little bit more? Yes?
The resin infiltration, there is a brand of resin infiltration system. So there is when you buy this system, there is armamentaria that goes with it, together with the material that you will be using. I'm not sure if it is in the Philippines already. I think maybe, but I haven't seen it. And there is a specific, you have to be, in training naman, hindi naman siguro ganun kahirap, no? So, but you have to be able to test it first para medyo masanay ka. And it will allow you to concentrate on one small particular area and not include a bigger or involve bigger tooth structures in your preparation. I cannot remember the name. But there is a system na merong particular brand. I'm sorry. So I have to look it up again.
Okay, no worries. But I guess the question for a lot of our co-dentists out there is that if this system isn't available here yet, will they be able to use the resins that they already have at their clinics right now?
As I told you, it is a system, and there is a particular armamentaria that comes with it, that goes with it. So you are able to load the material onto the let's say a loading syringe that they have, and that's how you are able to do the resin infiltrate. Will you be able to do it using the materials or armamentaria that we have now? Probably yes, but it will require probably a significant amount of dexterity. Maybe Dr. Vic Medina can do that.
I'm sure. Do that. It's Doc Ned.
Yeah.
Yeah, good to hear that you're here with us tonight. Next question, moving on to the next question, Dr. Tess.
Okay.
For the SDF procedure, how often should it be applied and reapplied?
The SDF, if you do it right, the SDF procedure would show you, it would manifest black teeth. That's why one of the expectations that you have to manage for patients is to tell the parent or to tell the patient himself that after application of the SDF, it will look black. At least where the carious areas are will look really black. So if it looks black after you apply the SDF, then that means that your SDF has really penetrated the dentinal tubules. So that is enough. But for a more effective application, experts are saying it's better to apply them twice. So after the first week, you recall them after another week and then apply a second layer. And that's how you are sure that you are really sealing all of the dentinal tubules. Now, after the second layer is applied, monitor the patient every 3 months. And if you're seeing a fading out of the color, then again, reapply the SDF. You'd like it to really look black and dark.
Yes, that is the recommendation, to do it at least twice if you can recall your patient and do the reapplication after a week. How do you feel, or what do you think about covering the SDF lesion with, say, a glass ionomer restoration after it has turned black?
It can be, yeah, but to make it more aesthetic, that is the purpose, right?
Yes,
there is
a lot of parents
right.
are saying, we like the easy nature of the SDF procedure, the treatment, but my child is going to go home with blacker teeth sometimes, right? They're going to go home with blacker teeth. Is there something we can do to make it a little more aesthetically pleasing?
Mm-hmm. So, sometimes I don't understand parents. Now, they bring your child to you, they have black teeth to begin with because of all the caries, and then they get concerned with SDF, which produces black manifestations as well. But of course, they're there because they want their child, the carious teeth treated, and of course, they want it done really nicely. Siguro instead of GI, kasi most of the time naman, yung ini-SDF, nasa smooth surfaces, di ba? Maybe better to cover with a crown. Not the stainless steel crowns, unless yun yung gusto ng bata. But if they want it aesthetically pleasing, then maybe a strip crown, or the more expensive, aesthetically acceptable crowns in the market. But GI kasi, you just have to tell them, sige, lagyan natin ng GI, pero malaking possibility kasi na matanggal pa rin eh. Especially if you have sealed in the dentinal tubules where the GI is supposed to chemically bond. So, saan pa sila kakapit kung nandun na yung SDF? So, maybe better to crown the teeth for a better look.
Right. True. Another fluoride question, Dr. Dev. Mm-hmm. Would you recommend a home fluoride treatment, especially at this time? And what is the best one?
A home fluoride treatment for so first, maybe if you want to recommend a fluoride treatment to your child patient, do a risk assessment first. So kung talagang nasa high caries risk yung pasyente mo, tapos medically compromised pa or special care patient pa siya, then I don't see any problem with giving them a home fluoride regimen, provided that somebody needs to be really responsible for providing it. Hindi po pwedeng makaligtaan. The instructions will have to be according to what you give them. And then, hindi ko alam, paano sila bibili ng fluoride? Papadeliver din, ganon? I'm not sure how it's done, no? Unless meron silang mahanap na readily available sa Shopee o sa wala naman yatang fluoride varnish or, di ba, topical fluoride available dun sa mga online markets eh. So, yes, why not? Provided that you have somebody responsible for it, but the challenge there is how do they get access to the fluoride varnish?
We have we have different answers right now because we are faced with varying conditions also. Stuff that we can ordinarily get before, it's not
Right.
easily available to us now. Yeah.
Right. We are really in uncertain times. Whatever we are doing now is like a precedent to what will happen also in future days. So I think depende na lang. It's a case-to-case basis. So depende sa situation.
Very true, Dr. Tess. Moving on to the next question. I think someone would just like you to repeat the concentration of the mouth rinse, the solution for the mouth rinse.
For the pre-procedural mouth rinse. The PPDSI recommendation is 0.2% povidone iodine or 1% hydrogen peroxide.
Yes, that's true. I think we're still all using that, but there was also a very recent recommendation of 0.5% povidone iodine, which can also be used for a pre-procedural rinse.
This is for pediatric patients we're talking about. The 0.5 povidone iodine.
Yeah.
Okay. All right.
Yeah.
Thank you.
Next question, Dr. Tess. In non-cavitated lesions and primary teeth, can resin infiltration be applied on occlusal surfaces? I thought it was only recommended on smooth surfaces only. A doctor is asking.
Can resin infiltrates be applied on smooth surfaces? Is that the question?
Can they be applied on surfaces? Because the doctor thought that it's only recommended for smooth surfaces, is the question.
Can it be applied on occlusal surfaces? That is the question. Nagchachoppy ka kasi. Occlusal?
Yes, that's the question. Yeah.
The recommendation from the ADA, Council on Scientific Affairs, recommends that resin infiltrates can also be applied on occlusal surfaces. But if you notice, if you took a picture of the decision tree that I showed earlier lifted from the ADA CPG, there is a sequence of treatment options that's listed there. So there is a reason for that sequence. So the priority treatment choice is the first one, followed by the second one, and then the third up to the fifth one. So for primary teeth, I have it here with me now. For non-cavitated lesions on occlusal surfaces, the first treatment option that you should choose should be sealants plus 5% sodium fluoride varnish or sealants alone. That's the first one. But if that cannot be done, then you proceed to the second one, which is 5% sodium fluoride varnish or 1.23% acidulated phosphate fluoride gel or resin infiltration plus 5% sodium fluoride varnish or with a mouth rinse. So, meron pong reason, hindi ko po nabanggit kanina, so thank you for this question. Because the sequence is according to the priority of treatment options. You cannot choose just any of them. Or you choose the second one or the third one only if the first one is not able to be done. So the answer to the question is yes. Yun yung according to the ADA.
Yes, it is. Moving on to the next question, Dr. Tess.
Yeah, sure.
The next question is, what does ADA stand for? I think
it's it's American Dental Association. Sorry for that. Hindi ko nasabi kanina. American Dental Association. So what I showed earlier is the guidelines, the clinical practice guidelines that they released in the latter part of 2018 from the American Dental Association.
Yes, we refer to the ADA guidelines and recommendations a lot too.
Yeah.
Next question, Dr. Tess. What Well, I think you partially answered this already. I think they are just asking very specifically what pre-op rinse or swab you prefer for a 1-year-old patient or below. So for infants. Okay. The question was, what pre-operative rinse or swab would you prefer for a 1-year-old or below patient for infants?
Ito po meron one of my patients is well, tatlo na yung patients ko na anak noong isang very supportive sponsor ng PDA at ng PPDSI. And the mouth rinse is, the active ingredient is essential oils. And yung panganay niya, when she brought her first child to me for the first visit, that was around siguro 1 year and 5 months old yung bata. The kid had white spot lesions almost in all her anterior teeth. And so at that time, medyo hindi pa ganoon kasikat ang silver diamine fluoride. And I think, knowing the mother, I don't believe that she will also like silver diamine fluoride for her child. So what we did was, case study lang to ha, I told her to diligently apply, swab on essential oil mouth rinse on all the teeth every night before sleeping, and that should be the last thing that should touch her child's teeth before sleeping. And actually, nag-work. Nawala, hindi naman nawala, but na remineralize yung mga white spot lesions. So from chalky white, nakita namin talaga na nawala yung pagka-chalky white niya, naging glossy na siya. Hindi na siya active lesion. This was just after 6 months. And she continued on doing that hanggang sa yung mga treatments na naka-line up for her child, we did not even do any of them. So this is just one case study, but I was very happy with the outcome of that case study. So, yun, pwede siguro yung gawin, but it has to be a diligent, responsible caregiver to do it every night for a patient who is 1 year old or below.
That's very interesting. I've heard a lot about essential oils, but we don't know a lot about it. Scientifically speaking, did they say what exactly were in the essential oils components? What combination?
They use the non-alcoholic brand, the non-alcohol containing brand. But I think that the variant is the tea something. Basta, well, na-pull out na yata ngayon. But they replaced it with another non-alcohol containing brand or variety. So as long as, siguro it can also be done using other mouth rinses. As long as, syempre pag bata, ayaw mo namang malasahan pag pangit ang lasa. Kaya mas maganda na non-alcohol containing siya. The povidone iodine, have you tasted povidone iodine? Actually, it's not bad tasting. I tried it on. If you remember, maybe some of the PPDSI members will remember, we had a lecturer a few years back, Dr. Peter Milgrom, and he was doing researches in the Latin Americas, and they were applying not the 1% povidone iodine. They were applying the 10%, yung antiseptic solution, on all the primary teeth in a certain area in Latin American country. and they were looking at its results on early childhood caries. And they were having good positive results with the application of the 10% povidone iodine variety. And so sabi ko, because of that, na-intriga ako. So gumamit din ako ng povidone iodine, 10%, and I tried to taste it. Oh, it's not bad tasting naman. But of course, with small kids, it's unpredictable how they might react. So it's better not to let them taste at all.
True. So many new things that we're learning today. Moving on to the next question, Dr. Tess. For a secondary tooth with fistula, is extraction the best option?
For a secondary tooth?
I'm sorry, for a baby tooth, for a primary tooth with fistula?
Okay. If there is a fistula,
extraction.
Right. The fistula is there because the abscess has eaten up certain parts of the anatomy that shouldn't have been involved in the first place. So yeah, for me, that would be for extraction already, because it's although we'd like a more conservative treatment, but we're talking about a fistula already. So we'd like the infection gone as fast as possible. So yes, if it were me, I would go for an extraction.
All right. We really have so many things to assess, right? Before we see what treatment is the best. Moving on to our next question. What do you think of CPP, ACP, or tooth mousse?
Calcium, I forgot what it stands for, ang haba kasi, no? But yeah,
calcium
tooth mousse.
Phosphopeptide amorphous calcium phosphate.
Right. I remember having Professor Dominic Zero as guest here, and for those of you who are not familiar with him, Professor Dominic Zero is a very well-known preventive dentistry expert, and I asked him the same question regarding tooth mousse, and he said that so far the researches that have been coming out supporting tooth mousse are researches done by the same company that is releasing the said product. And until now, I have not seen any researches by a third party, meaning not involved with the company or with the proponents of tooth mousse. So I have not seen any researches that would support the claim of tooth mousse so far also. When I was in Conken, I also tried looking it up and asking my professors as well what they can say about tooth mousse, and it's the same answer. No research to support the claim of tooth mousse yet.
Oh.
Hindi ba mas murang sorry sa tooth mousse, pero mas murang bumili ng tamang concentration ng fluoride-containing toothpaste kesa tooth mousse. So I would go with toothpaste. It's more cost-effective now. Yeah,
since you did mention it, would you like to tell everyone the fluoride concentrations that are recommended for every age group?
Yeah, sure. So for those who are children less than 3 years old, we hope that you'll be able to recommend a fluoride-containing toothpaste that has 1,000 ppm, parts per million. So to see that, you look at the back of the box of the toothpaste. It should say there 1,000 ppm. And then for the older kids, it can be like 6 years old and up, can be 1,500. Actually, that age group can use the same toothpaste that their parents are using already. Kung medyo, di ba, minsan kasi isa lang ang ginagamit ng buong pamilya para isa lang ang bilihan. So, kung 6 years old and above, pwede ng 1,500 parts per million ang gamitin. And those below 1,000 ppm.
I think we can move on to our last question. Why was risk-based reassessment added to the Caries balance chart?
Caries risk assessment is now considered an important diagnostic tool by many experts. There are two types of Caries risk. This is an entirely different lecture, and I can I can lecture again another time for Caries risk assessment. But to put it simply, you have to be able to identify your patient's category. If a patient belongs to the low risk for caries or the high risk for caries, I think for the Philippines, there are only two categories, nothing in between. It's either low risk or high caries risk patient, or maybe even a really high caries risk patient, no, for the third category. So if you are able to identify the risk category of your patient, then it's easy to identify the preventive programs that you can recommend for that particular patient. So it really is tied up with having a good dental home and having an infant oral health program, so that you can focus on preventive strategies. And now the trend is really on providing not restorative interventions, but more on preventive strategies. And if we can only do that if we go as early as possible in our patients. That's why caries risk assessment is now becoming a more important tool, especially with younger children and also with public policy making decisions.
Yes, that's very true. And it's not it's not cookie cutter anymore. We really need to assess our patients, each and every one, so that we can give them the best possible treatment for their particular needs, right?
Right. Hopefully, we'll have our very own. Hopefully in the future we'll have a customized caries risk assessment for Filipino children lang talaga. Hopefully, well, that's my dream. So maybe in the future, after the pandemic is over, we can do that.
Yes, that's a very, very noble, very, very worthwhile project. And I'm sure all of us at PPDSI will be working towards that goal with you also, Tess, Dr. Tess.
Thank you.
Moving on to next question. What is the best SDF brand?
Parang dito sa Pilipinas, 2 o 3 lang naman yata yung brands.
Yeah.
Pero marami pa kasing brands outside the Philippines. I don't think the brand matters much. What matters is that it is applied correctly. Kasi pare-pareho lang naman yung concentration ng silver diamine fluoride. So if you know how to apply it properly, regardless of the brand, you'll be able to achieve the effect that you'd like to have.
I think we will be closing our question and answer forum for tonight. And we would like to thank once again one of our very own, one of our past presidents, Dr. Tess Villarico, for gracing us with her presence and for giving us such a wonderful lecture. So Dr. Tess, let me just read out our certificate of appreciation that we will give you a soft copy of, since we will not be able to give it to you personally. The Philippine Pediatric Dental Society Incorporated presents this certificate of appreciation to Dr. Maritess Oliveros-Villarico in grateful recognition of her participation as guest lecturer and for sharing her expertise and knowledge through the topic, The Road to a Clean Bill of Pediatric Oral Health. given this 29th day of June 2020 during the PPDSI String of Pearls webinar series. Signed, Dr. Rowena Castro, Awards Committee Chair, Dr. Paul Abaya, President, PPDSI, and Dr. Hazel Marie Tala Sunico, Scientific Committee Chair. Once again, Deb, thank you so much.
Thank you.
Wonderful, practical, very informative and enlightening lecture. Thank you so much.
Thank you also.